Good morning, and on behalf of the IALP Cleft Palate Craniofacial Conditions Committee, I welcome you to the first of two webinars that will be presented by the IALP Committee, Cleft Committee, and that is called Basic Overview of Feeding in Non-Syndromic Cleft Palate. My name is Linda Volino Napoli, and I have the honor and the privilege of being chair of this wonderful committee, following the extraordinary leadership of Dr. Valerie Pereira, who served as chair for 6 years. And I'm also very privileged to be able to work with such talented colleagues on this committee. I would also like to introduce to you our deputy chair, Michaela Bao. But before I introduce our speakers today, I would like to provide you with a quick overview of the committee and its work on the program. Next slide. Okay, thank you. The committee is a very busy one. And you can see here we have 8 members and 3 consultants representing a wide range of geographical regions, clinical academic research, and mentoring skills and experience. For the past 3+ years, the committee, really under the leadership of Dr. Pereira, the committee has engaged in a wide variety of activities, including the development and publication of resources, running a series of webinars, mentoring colleagues from LMICs, as well as providing webinars and Q&A sessions for the Transforming Cleft IALP Speech Mentorship Program. Various committee members have also been active participants on Global Speech Task Force and international conferences and committees. And I would like to remind you to be sure to join us for the upcoming webinar in November, November 5th, on early assessment and intervention for cleft palate speech and language. And you can register by accessing a link that will be sent to you. And before I introduce the speakers, our committee would like to thank the committee for selecting our webinar topics. And I'd also like to thank Michaela and Chelsea for working in orchestrating the Zoom seminar so we can get started. Feeding an infant with cleft palate can be challenging for the baby and mother and caretaker. There are specific anatomic and physiological challenges and feeding adjustments and techniques that have to be made. This webinar aims to provide attendees with an overview of these challenges and ways in which they can be overcome that will result in a useful feeding strategies to ensure proper nutrition, promote healthy growth and development. And so it is my pleasure now to introduce the speakers of the webinar. Okay, Erica Bostock, Karen Goldschmied, and Carolina Rivera. They are cleft specialists who have an incredible amount of knowledge and skill in the area of feeding. And we thank you so much for presenting today.
Thank you, Linda, for the introduction, and thank you, team, for being here. So hopefully this basic overview of feeding a non-syndromic cleft palate will give us a hint of what to do, what do we expect with these children that have an anatomic problem that could affect feeding. So next, please. So we want this little table of content. We want to go briefly over anatomy and physiology, understanding the non-syndromic cleft palate. And here I want to focus over isolated cleft palate. We won't talk in this webinar about syndromic cleft. This is another group of patients that we have to take in account. Feeding challenges in infants with cleft palates, and then go over assessment and some strategies and intervention that could help us. I want to make an emphasis on the meaning of effective feeding. Normally, when we think about feeding, the first things that comes into our mind is nutrition. And we tend to associate feeding with, is this child gaining weight? Does it look nice, healthy? And we sometimes forget about what involves safety of the airway and satisfaction. Do I like to feed my child? I'm uncomfortable feeding my child. And on the other hand, is the child enjoying being fed? So when we have all these three, satisfaction, safety, and nutrition, then we can only talk about effective feeding. If not, we have a feeding disorder, and it involves anxiety and conflict, and these implications in the development of the child. Next, please. So I like this graph because it tells us, it shows us like mathematically, we need safety, we need satisfaction, and we need nutrition. And if these all three points get together, then we have success. Next. And we can't forget, next please, and we can't forget about what is feeding? How does it occur? Do we need to be taught how to feed? Do we need to have a special education? And how can I try to do my best in a child who is coming sometimes with an anatomical disorder of the mouth and the orophageal system? And feeding is just extremely efficiency, but it involves lots of different complex systems, neurological, anatomical, functional, environmental. So we need to coordinate sucking, swallowing, breathing with all these multiple complex systems. We can't forget about the characteristic of the infant, like comorbidities. How is the personality of this little child? How is the environment? Is this a teen mother? Is it a mother who had other feeding experiences before this child? Does the family has a prenatal diagnosis of the child who is coming with cleft? All those environmental factors will affect feeding process, and we have to take this in account. So that's why we talk about feeding process as a multidimensional thing. It's not only the anatomical problem, we have to take in all these other parts in account. And therefore we need a multi-professional point of view and involvement of many, many specialists sometimes. Next, please. So this is very basic. We took this from the Glass and Wolf book, and it's important because it's for all children. It's not only for cleft-related patients. At the beginning, when we start sucking, we can only create positive pressure. It's like just chewing, and the tongue goes against the palate. And with this generation of positive pressure, the fluid draws out of the nipple. And so taking account, if we have a wide open palate, where can the tongue press against? Sometimes against the vomer, sometimes it's too wide, sometimes in a cleft with only unilateral implications, it may be different and easier. Next, please. But once we're needing more liquid, more nutrition, this positive pressure has to be more efficient. And we need, therefore, to create a negative pressure. For this, we need a sealed oral cavity. This means in the anterior part of the mouth and also posterior. And once the tongue and the mandible goes down, this enlarged and sealed chamber will generate negative pressure, and the child will could then draw more liquid with and more efficiently and more volume. So once again, go back to our children with cleft lip. When there is an opening of the anterior part of the mouth and sometimes also posterior or both, that this pressure could be then diminished. Next, please. So this is a graph, a table that shows us the feeding components of a child with only cleft lip, with cleft palate, with cleft lip and palate. And the little group, it's stated here as Robin sequence, but those children that are associated with breathing problems or airway problems, such as Robin sequence. So most of the time, our child with cleft lip and palate will have mostly difficulties in generation negative and positive pressure But as you see, swallowing and respiration will be stayed unharmed, and those children are healthy if there is nothing associated as a comorbidity, such as neurological cases, for example. So suction and compression in cleft lip is not as diminished. Cleft palate, yes, the generation of negative pressure could be very, very problematic. And with cleft lip and palate, more negative pressure will be absent. Next, please. But this is our dream. I would like to show you that we have a cookbook, and you can go to the cleft lip and alveolus child only and look, what shall I do with this child regarding feeding, or in submucous cleft palate, or cleft palate only. But next, please. This is not always the case. And yes, in this book, they try to do something like this. Which feeding method can I use when I have a child with cleft lip? Normally, they are suggesting us nipple with white base, or actually, we would love to have child, generally possible, to be breastfed. What about cleft palate? It's different in a small cleft than a large cleft. Yes, possibly with small cleft or submucous cleft, we could also have breast, and sometimes we need to assist or to make a mixture about bottle feeding and breastfeeding altogether. And then in cleft lip and palate, those are the children that are the most challenging, and moreover, those with syndromic characteristic. Next, please. So I wanted to show you these patients because this is what a book tells us. But what does actually the clinic tell us? That our children, our patients are all different. And sometimes even a little cleft will be challenging for us. And sometimes with the children with white clefts, even with syndromatic characteristic, they won't be challenging as another child with only cleft lip and palate, for example. So even it's written on books, we have to take in account that every child, every patient, every family, remember the environment, is different and unique. Therefore, we have to take this in account to making the best approaches as we can. Next, please. So I want in the next slides to go over each of these different characteristics of children. Next. What about the cleft lip and alveolus only child? Actually, they don't have significant problems. They shouldn't if it's only a cleft, isolated cleft. The anterior labial seal is possible. Some groups use taping. It's not really stated if it helps or not, but you can see some teams using a taping of the lip to afford a better anterior labial seal. But remember that the breast tends to adapt and fill that cleft and make the overall anterior oral seal. And if the mother doesn't want to feed by breast or has problems, or the child isn't gaining weight, we suggest to use nipple white and soft base feeding method with expressed milk. Next, please. Submucous cleft palate, that's another area. But again, if it's only a little submucous cleft palate, or even sometimes soft cleft palate, there is no significant problems using breast milk, or even fed the child directly to the breast, because the posterior lingual elevation of the tongue supports the generation of the negative pressure. And yes, we have to take into account that in these children with a cleft palate, even if it's a submucous cleft palate, nasal regurgitation, that means the drawing fluid, milk out of the nostrils, is possible, and this can be avoided or minimized using an upright position and like sitting the child in the arms of the mom to avoid this. But this is the child who will be more challenging for us, the one who can't afford to generate the negative pressure that is needed for drawing a lot of fluid out of the nipple or out of the breast. The poor oral seal won't allow to generate positive pressure and also negative pressure that is needed. And yes, there's only one big chamber, oral nasal chamber is together. So nasal regurgitation is more visual in this child. The child may be disorganized. It may be having discomfort in being fed. There's an increase of areophagia. That's challenging also the prolonged feeding time. The child feels satisfied earlier, and thus doesn't help us to deliver the nutrition needed for gaining weight. We have to take in account that a child has to be fed not more than 20 to 30 minutes. So if it's a prolonged feeding time, this plays a significant role in not gaining the nutrition needed for growing. Next. So I have to, even if this webinar we won't be talking about syndromic cleft palate, I have to take this slide very important, because these children are challenging, and these are the ones who we need to see in a multidisciplinary team. Yes or yes, there is no maybe. The airway safety of those children are challenging. Nutrition is very effective. Sometimes they have cardiac problems, renal problems, that will make the nutrition even harder, and the psychoaffective area also. So these children need a special attention, and maybe in a third or fourth webinar, we will talking about those little group that is our challenging group. Next. So now we know that there are deficits in intraoral pressure, that they may be nasal regurgitation and risk of aspiration in some children if bills are very disorganized, and this will impact the weight gain and energy expenditure. Next.
So what do we do?
Yes, Carolina, please.
Thank you. So, sorry, technical problems. So what do we do? Swallowing issues can be multifactorial. It can let us think of what do we do with our families and with our patients. So one of the most important things here is to reinforce the importance of a team-based care. We have to understand that we as a speech cannot do all of the work ourselves. So when we should be considering doing the referral or why, the first thing is, as Karen mentioned before, the airway problems or respiratory problems that can lead us to hospitalizations. Also, the gastroenterology for reflux, and also one of the most important things here, because it will be related to all the surgical process and all of the procedures that the kid will receive, it's the intake calorical and the growth concerns. Directly speaking of the studies, we have two studies. We have the FEAS and the BFSS. The FEAS is a study that is related to visualization of swallowing using a flexible endoscope. And by the other side, we have the BFSS, sorry, that is a radiological study of swallowing with contrast material. And when we should be thinking about using this kind of studies, when we suspect of aspirations, also when we consider that the different postures that the parents are using are not the correct ones or the safest ones. And also, if we have to consider if the baby needs a different thickness of their liquids. Going specifically with the different studies, in the first one, that it's the BFSS, it's best for doing this evaluation of the oral pharyngeal and the first stage of esophageal swallowing. It also can lead us to see better the body's movement in real time. And this will help us to check all these structural and mobility issues. It also helps us to measure the risk of aspiration with the different consistencies if we are trying to explore with these options for the families. But the other side, this is the best detail for the pharyngeal and laryngeal structures. And we can use this for check the airway protection before and after swallowing. Also, if the baby has secretions, or even though if the baby gets very easy fatigue when it's having the baby bottle. So it's very important to clarify that we do not have to do these procedures by ourselves, and it remarks that we have to work as a team-based care. Also related to that modification of the feeding techniques, we have to check very very detailed the posture changes, because sometimes when we work with the families, they're like, no, in home we work this, we feed the baby this way, or we do this with the pillows and different things in the bed. And sometimes this incurs in respiratory problems. So it's very important to check the posture. Also, if the baby it's feeding very fast, or if the baby bottle is not the correct one. And we have to consider as very important that, as Karen mentioned before, every family and every baby, it's unique. So we have to individualize the strategies for the family and the baby itself. Also, when we consider the special elements like the baby bottles or the cups, we have to understand which one do you have in our country, because sometimes, and it happens very frequently, parents start checking online and they're like, oh, I can bring this baby bottle from another country, or oh, I was reading that this one works perfectly. And it's not only to have the baby bottle or to read about it, it's to understand and have the support of how to use it. It's not about only buying it, but how to use it correctly, because none of the baby bottles that we think it will use to the babies will work it correctly. Also, we can have these options of different spoons or cups for babies who has major difficulties feeding. And also, when we have this consideration for gastrostomy tubes, we have to understand that we have first to organize and see if the baby has a really complicated oral feeding, or it's unsafe or insufficiency for nutrients. Also, if it's a really high risk for aspiration, and this will probably send into a different group of specialists for analyze if it's better to get this tube or not. And if it gets, it's very important to continue doing the oral stimulation as possible. Next, please. So this information can reorganize in these 3 points: the early involvement of multidisciplinary cleft team. And I will repeat again, as Karen says, it's very important that the family receive the information of the diagnosis of the cleft early. If it doesn't happen, it doesn't matter. But if the mother during the ultrasounds get the information, it's normally that it tends to have these negative thoughts, or I will not accept, or probably I will be waiting until the baby is born. But when we start working very early, it's better for the mother to get all the information related to the feeding. Also, closing monitoring for weight gain and feeding safety, it's very important because obviously during these first months, we are preparing this baby for this surgical procedure. So if the baby doesn't gain weight, probably the surgery will go after. And also, this is structured feeding education, and it will come with all the information that the parents receiving in early management. If they it always tells that it doesn't matter how many times you explain the same thing, parents need an extra mile for it because they have a lot of situations going on at home, and we have to understand that it's not only to get the correct feeding for the baby, it's to understand also what's happening at home. And all of these 3 points are focused in improve the baby's growth and reduce the feeding related complications. Next, please. So now we're gonna be talking about assessments and evaluation. Next, please. So first, with related to the feeding assessment, we have these clinical observations that will explain the first step of watching the baby being fed in a natural way. It doesn't matter if it's first breastfeeded or if it's use a baby bottle. So what we do is describe what we are looking, if there's an alert signals, or if we look for this baby caregiver or baby mother interaction. Also, if there is sign of stress, not only the baby, but in the caregiver or in the mother. And if the baby is coughing, if the baby is crying, if it's change in the color of their lips. And this thing related to the stress is very important because we have to consider that in the real life context, parents have a lot of stress when the baby is coming in home, and they do not expect a lot of medical appointments or the stress related to the surgery, but before the surgery you have to gain weight, so it's a lot of stress related to how you can feed correctly and safely this baby. When we talk about the examination of the oral structures and function, we have to check correctly how does the lip, how does the tongue, how does the palate or the jaw starts moving. It doesn't matter if it's correctly with the breastfeeding or with the baby bottle, because as you have seen before, we can use both options. And what are we going to be checking? Well, we're going to be checking for strain, for tone, for symmetry, and for motion when it's taking the seal. And also, it's very important here to have these checking if it's leaking the milk or if the baby has weakness, to have this suction. Related to the parental report, we have to explain to the family to, before all of this process, take and like manage at home these day-to-day like diary, so you can like write what is the reaction of the baby, if the baby enjoys eating, if the baby has this correct position, does someone starts feeding the baby and it didn't do the correct position. So it's better to have this all right, and then we can ask like with dates or even with the road process. We can also see if there is a feeding time length or if it's choking or coughing episode. And it's highly important to like understand that this is a collaboration of the family and the team-based care. So it's very important to have an open communication. Also, we have to see how it's the head posture, how it's the mobility with the mouth, and these will lead us to this suck, swallow, and breathe coordination, because we can see if there's occurring fatigue, or if there is an aspiration, or probably like Karen mentioned before, this long timing when the baby is having the feeding. So we have to always be safe and focus in these correct positions for safety and efficiency. And we have to focus on the better airways protection and that the baby is gaining weight. Next, please. Next, please. So in the early intervention, we are focusing in how does the baby is fitting in the arms or the correct position of it. Also, if this a correct position, not only with the arms, because sometimes the parents are like, oh, because the baby is getting weight, it's more tired for me. So try to understand and give different options for not only make comfortable the process of feeding for the baby, but also for the caregiver or the mother. Also monitoring the body posture and the head, and it's very, very important for establish eye contact. In my country, they say that, oh, because you are not breastfeeding the baby, probably the bond between mother and baby, it's not as stronger as you think it will be. And it's not correct. You can have a great and a strong bond with your baby, even when you're using a baby bottle. But it has to be part of this to have this eye contact, to talk to the baby, like motivating the baby, or even though like sweet words of support, but probably it will not for the baby, but for the mother itself, but it works. And also to have the baby and doing this process in a place that it should be comfortable for the interaction. Next, please. So it's very important to check the jaw and the cheek support for giving the stability for the suction, and the body in head position for not produce any aspiration problems. And related to the shortening of feeding time and feeding exposures, it will be for avoiding the fatigue and stress, not also for the caregiver or the mother, for the baby itself. And we always know that if it creates us stress, it will give us negative experience. So this shorten its focus for safety, it's better, and prolong it for not having exhausted babies, because after 30 minutes, probably the baby will start losing all this energy that it's getting for the body. And also we have to focus on creating opportunities to experience oral feeding. Next, please. Okay, next, please. So I will let you all to Erica.
Thank you very much, Carolina and Karen. Although in the West, breastfeeding and breast milk are not so much focused on in low-resource communities and countries, breastfeeding and breast milk are essential for the nutrition of a baby with a cleft palate. We look at this as nature knows best, breast is best. However, the action of, and because of breastfeeding stimulating the ideal oral motor development, we really try and promote breastfeeding amongst mothers of babies with cleft palates in low resource settings where they don't have access to speech therapists and other therapists as easily as in high resource contexts. So breast milk is the ideal food because it is free, and this is a big issue in many low-resource contexts. It also comes at the correct temperature. It has the correct nutrients, consistency, and concentration, and these adapt to the baby's needs. For instance, on hot days, the breast milk is much more watery than on cold days when it will have much more fat. It is also sterile, and it contains antibodies to strengthen the immune system. And this helps particularly to protect against middle ear infection. Next, please. However, not all mums can breastfeed. So we need to look at two considerations: how to feed and what to feed, bearing in mind that the ideal is breast milk. Next, please. Directly from the breast is ideal, but it's not always possible. It is very exhausting because it is hard work for the baby, as they only get the milk from the compression of the breast. And if the cleft in the alveolar ridge is very wide, the compression of the breast may not be very strong. It also depends on how strong the muscles of the cheek are. So what many mums do is that they express from their breast by pushing in against their breast, pushing the breast towards the nipple to support the baby's efforts while the baby is latched. And they do the squeezing of their breast in time with the baby's compression of the breast. However, this may not be possible, and sometimes babies do not get enough milk, or they run out of energy quite quickly and tire while they are breastfeeding. So they may need to augment this with cup feeding. So a mum may start off with breastfeeding, with supported breastfeeding, and then move on to cup feeding. Or if the baby is unable to feed at the breast altogether, we look at cup feeding as a very positive alternative to breastfeeding. Cup feeding encourages the baby to control the feeding rate, so the baby is less likely to aspirate the food, the milk. And it also encourages oral motor activity. Cup feeding is also hygienic because the cup can just be washed with the rest of the household's crockery and cutlery and air dried. It doesn't need, the cup is hygienic because it doesn't have nooks and crannies where milk can get stuck, and so it doesn't need to be sterilized. It is also possible to feed with a spoon or a syringe, but one must be aware of hygiene issues with syringe feeding and also the cost of regularly replacing the syringe. A spoon or a syringe is a more passive way of feeding. The syringe is often used just for a day or two while introducing oral feeds to a baby who may have been born prematurely or who wasn't able to feed orally initially. Next, please. Here's a picture of a baby being cup fed. The cup is tipped up until the milk reaches the baby's lip. The milk is not poured into the baby's mouth ever, as this is a risk for aspiration. So the baby is held upright so that they can control the milk that comes into their mouth more easily. And they then stick their tongues into the milk, and the milk runs along the edge of the tongue because it's wet and is drawn into the mouth that way. The baby laps the milk up into the mouth, and that's why they can control the rate of feeding, because at no point is the milk poured into the baby's mouth. Next, please. Bottle feeding is the ideal, and it's really the ideal because it is marketed so well by the companies that produce bottles and formula. If there were more marketing of cup feeding, I think it would be much more popular amongst mothers, because it really is a very positive and easy way to feed, and can actually be faster than a cup, because babies learn to feed much faster. They get control over their mouths quite quickly when they're cup feeding. When we're looking at bottle feeding, we must consider the AFAS criteria of the family. Is bottle feeding acceptable? Is it feasible? Is it affordable? Is it sustainable? And is it safe? And these criteria vary, the answers to these criteria vary from family to family. Every family and every baby is an individual. Could I have the next one, please? Cleft lip is usually not a hindrance to breastfeeding. It may be necessary to position the baby so the breast fills in the space in the lip. And this is usually done in a unilateral cleft lip by putting the baby with the cleft lip on facing downwards. The cleft palate, as we've seen before, is problematic for feeding because of the compromised suction. and then very much effort for a little milk, which leads to exhaustion and therefore inadequate milk intake and possible malnutrition. Because there's less stimulation of the breast, there may be a poor milk supply. And so mums need to take care to stimulate the milk supply by expressing milk regularly. Nasal regurgitation can be overcome to a large extent by feeding the baby upright so that gravity keeps the milk away from the nose. Feeding may also be compounded by other facial abnormalities such as Pierre-Robin syndrome, but that is for another time, a discussion for another time, as Carolina said. Next, please. Feeding considerations in low-resource settings are as follows. Specialized bottles and teats are rarely available, accessible, or affordable. Formula is often unaffordable and in very rural areas unavailable. Clean water and fuel for heating water are often not available and/or are very costly, making hygienic care of bottles challenging, as well as having sterilized water for mixing formula can also be difficult. And because of these factors, breastfeeding or the feeding of expressed milk, breast milk, should be the primary aim of feeding intervention. Cup feeding is a method of choice for feeding expressed breast milk to babies who are unable to breastfeed successfully in low-resource settings. Next, please. We must also bear in mind that specialized assessments such as video fluoroscopy and fees are very, very rarely accessible or available or affordable in low-resource settings. So mothers may need assistance with being taught supported breastfeeding, positioning to minimize nasal regurgitation and aspiration, manual expression of breast milk, safe storage of expressed breast milk, how to stimulate and maintain the supply of breast milk, techniques for burping the baby, ensuring that the baby gets hind milk and not only fore milk, how to cup feed safely, and troubleshooting for various difficulties with breastfeeding and feeding of breast milk. In addition, it is essential to provide counseling and support for mothers who support difficulties with feeding their babies, as this carries significant stigma in many cultures and communities. Thank you. We will now go on to the questions and answers.
Before we do that, I want to thank you for a wonderful, wonderful presentation. I always learn so much. Okay, and I do have a question. But before we move on to the questions, I just want to ask, I have been reminded to ask the attendees to put their name, country, and an email in the Q&As so that you can receive your certificate of attendance. Okay, thank you so much for that. I do have a question. May I, to start this off? You so eloquently talk about the families and their involvement and how you're sharing with them how to feed the baby and that sort of thing. And you're really, you stay in the game there. How do you reconcile sometimes their own values and beliefs, and maybe even their preferences, with the things and the techniques and strategies that you're sharing with them and the information?
I'll answer that one, if I may. The most important thing is to make families feel heard. If you acknowledge their questions and if you need to ask for their opinions, their feelings, and what their values are, what their preferences are, and then explore those with them and look at them from a practical point of view, and gently and respectfully point out where difficulties lie, where there are conflicts between what they would like to do and the reality of the situation, and ask them whether and ask them to problem solve. So if you can say to them, this is the problem, this is why X doesn't work. For instance, feeding from a hard bottle. This is why it doesn't work, because the baby isn't getting enough milk because they can't suck from the bottle. How can we adapt that? Are they able to get, for instance, a softer bottle so that one makes compromises on what they would prefer and what is realistic. And sometimes you know one has to give them a chance to try and see that it doesn't really work. As long as the baby is safe, is feeding safely, so absolutely not feeding the baby lying flat on their back, because that's an instant recipe for aspiration. You know, I think that there's some families need to see for themselves that what they would like doesn't work. But usually they're very open, and they've usually had a couple of days of experience with their babies, or weeks of experience with their babies not feeding adequately and being hungry all the time. And the mums are frustrated and at the end of their tether, and really worried about this baby, because they can see it's not doing well and it's losing weight. So they're usually very open to any suggestions you can bring. And when they see that something like cup feeding really works, and you show them that many babies, it might be a little messy for the first day or two, but that they learn to do something like cup feeding very quickly, and how well they feed, and you show them and you support them in feeding, doing the cup feeding themselves, so that they do it with your supervision, and you can point to things that are working for the baby, and help them to help them to be aware of the baby's cues for feeding, like when the baby needs to have a break. Then they feel a lot more confident, and when it works for them, just that confidence and that relief of this is working usually is enough to overcome any initial hesitance that they had, and that makes them more willing to work with what works rather than what they wanted. And I think the important thing is to make them feel respected and heard. The most important thing is that they're heard, that you're not just automatically applying something and you're making them feel worthless. You have to support them and point out their value, and their value as a caregiver in feeding, and that this is, you know, we're only involved very temporarily, but the caregiver is there for the rest of the child's life, and that this is life-saving. And very often it's, they had dreams of breastfeeding and now that's not possible. So changing the value system, making them see that even if breastfeeding isn't possible, giving expressed breast milk is the best thing they can do for the baby, and has tremendous value in supporting that baby and extending its life. And yes, it is very often a life-saving measure.
Thank you. Do we have any more questions here?
We have lots of thank yous in the chat, but if anybody has a question, feel free to pop that in the Q&A box as well. But yeah, lots of thank yous, and that it was very informative. So thank you all. We'll wait a couple of minutes anyway to see if anybody else has a question or two.
We can continue the conversation, and if somebody has a question, you can interrupt. I don't mind.
Please go for it.
I have another one again.
I have a question. Speak of the devil.
Good.
So we have a question in the chat. Is there always a cleft team? Would you start with feeding even if they're not in the, even if there's no team in the background? So is there always a cleft team in feeding? Would you start with feeding even if there is no team in the background?
Shall I take that one again? There isn't always a team with feeding. Very often, the clefts are not that common and people don't know what to do. Very often it is the speech therapist who is responsible for feeding. Some countries now, and especially some of the cleft organizations, are working now at developing nutrition teams. And they are very much taking over the role of the speech therapist in the countries where they provide intervention. So it is, then there is a lot of partnership and work between the nutrition team and the speech therapist. Sometimes, though, there is no speech therapist, there are many countries in the world which don't have any speech therapists at all. And so then it does fall to nutrition to do that. It's usually a sort of direct correlation between how well resourced the country is and how big the cleft team is with regard to feeding.
in Chile, for example, it's joint work. So sometimes we don't have a team, but there is the nutritionist or even the nurse or the pediatrician who is taking care of that baby. But anyway, I would suggest in those cases where the air safety is an issue, then you have to look for another team, another specialist that will help you. So safety is first, and nutrition, of course. And if that's the case, then you need to scream for help. And probably what I'm always trying to see in those, we talk always about the differences between low middle income countries and those countries who have everything and not just a team, but a whole hospital only for cleft. It's a huge difference in what we can do and what can we give to the parents and the families. But saying that, we have to always look forward and not less. So if it's needed, a team, or if you need a specialist, we have to use the resources and the different partnerships to find those who can help us and teach us. That's what we are here together today.
And we have a follow-up on that from Alexandra. If you are in a rural area, there would not be a team, and I'd be hesitant to start feeding. Any thoughts on that?
Again, if safety is an issue, then yes, Alexandra, I would suggest to be very cautious in oral feeding. But if it's a cleft, isolated cleft, once again, normally we won't have feeding issues in related to airway safety and nutrition. So those children who will be our challenging children, our challenging babies, are those with comorbidities. So yes, in a rural area, if there's no team and you have airway issues and safety issues and nutrition issues, maybe oral feeding would be appropriate. But if that's not the case, go for it, because a child with cleft, isolated cleft, shouldn't have such trouble if you make the correct amendments and positionings and cup feeding or breastfeeding, with obviously follow up in gain weight, in nutrition, hydration, and so on.
Thanks,
Can I
Karen.
just add that in very rural areas and very low resource countries, things like feeding tubes and gastrostomy tubes may not be available at all. They may not be an option. And your question that the risk then is, do you risk an airway or do you risk death from malnutrition? It's really difficult to make those choices. But I agree with Karen that if the child is not syndromic, or the syndromic features do not affect the rest of the structure of the face, for instance, like Pera biosequence, and don't affect the child neurologically, the chances of having airway issues are much smaller. It's really where there are neurological issues which can result in aspiration, or where there are structural issues which can affect the airway, that feeding is really dangerous. Otherwise, it's fairly safe to feed a baby with a cleft palate, as long as they're fed upright and slowly, to minimize any problems.
Thank you, Erica and Karen. I have one more question that we might take. I work with some adults with disabilities and they would still have cleft palates. I'm taking that as unrepaired cleft palates. They are currently NPO. Would you have any experience in this and any advice?
I have to ask, what is NPO?
I think it might mean nil by mouth for me, or non-oral. Is that
Non-oral.
what it means for other people? Yes. Okay.
Yes.
Non-oral?
So tube feeding, I'm assuming.
Thankfully, I haven't got that experience.
This might be a whole other webinar.
I don't know, Erica.
I don't have experience with adults with clefts being nil per os. I have experience with children, with toddlers having been fed by a nasogastric tube because of a cleft palate, and the child was non-syndromic. It was just that the care team had very little experience with clefts and didn't know that it was possible to feed safely. And we did trial oral feeding, and the baby took to it like a duck and was perfectly safe. I would say that if the adults are swallowing their saliva safely, they should be safe for oral feeds. I would proceed quite slowly, because obviously not having swallowed anything other than their saliva for their whole lives, probably start with drinking, with increasing amounts of liquids, and practice chewing, do the liquids and then soft solids, puree diet, and then going on to chewing, practicing chewing, and practicing maybe chewing on, maybe to practice chewing if they haven't done so yet, chewing things that they aren't going to swallow first, maybe chewing gum, or sucking on ice and things like that. So there's a slow release of saliva or liquid going into their mouths and into their systems. Apologies for my dogs in the background.
And I do think also that you have to consider the disabilities, because if the person cannot understand or follow instructions, it will be a risk. So it's always to have this space for explanation and the correct follow instructions.
These are excellent points, and I'm glad that question was brought up. Food for thought. On behalf of the entire committee, we thank you very, very much for your very, very fine presentation. I know that I took my notes, and I think we are done, right? We look forward to seeing you at the next webinar. And again, many, many thanks. And thank you, attendees. We appreciate your coming here.